blood in the vomit, blood in the stool, blood in the diaper. These presentations can be tricky. How far do I go in my investigation? What do I really have to worry about? Gastrointestinal bleeding in children. When is it frightening? When is it fine? And when is it a formidable foe?
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. GI bleeding in children can be life-threatening or just plain meddlesome. The differential diagnosis is broad. We need some framework to sort out the minor, self-limiting mucosal irritation from the harbinger of a massive bleed. Let's go through the top 3 dangerous diagnoses in each of 3 age groups: neonates, young children, and school-aged children and adolescents. To cut to the chase, any GI bleeding in the less than 1 month crowd is serious until proven otherwise. Paula is a 3-week-old baby girl born full term without complication who was brought in by her father after Paula had one large bloody stool that Dad dutifully wrapped up and now frantically rushes to open to show you. It is a full diaper with dark blood and a few flecks of brighter blood mixed with mucus. You thank Dad for his diligence. By report, Paula is a healthy, thriving neonate, taking 3 ounces of formula every 2 to 3 hours with normal stool and normal urine output. As far as Pops can say, but he explains, "My wife had to stay home with our 2-year-old. He's been having more tantrums lately now that Paula's with us." Dad is obviously involved and caring, and he fills in the blanks as much as he can. You can see that he's nervous. You sit down. "I can see you both are doing a great job with Paula," you say. "You're just trying to help the poor guy settle a bit." Paula is well-appearing, maybe a little pale, but she is vigorous. She's active and alert with good tone. Her head-to-toe exam shows normal mucosa, no signs of trauma, no distress, no rash, no organomegaly. She has good perfusion. Her total body check is normal. Her rectum is normal. Her stool is dark and hemoccult positive. Now what? In a well-appearing neonate with GI bleed that is not an obvious minor rectal fissure, it's prudent to check a complete blood count. Paula's hemoglobin and hematocrit come back normal for age. So now what? The 3 most dangerous diagnoses in the neonate are necrotizing enterocolitis, malrotation with volvulus, and inherited coagulopathy. These children are all ill-appearing. Now, it's important to note that 15% of necrotizing enterocolitis occurs in full-term babies. Malrotation may simply present in shock without initial overt bleed, and inherited conditions may not be known to the family early on as they haven't heard back yet from the neonatal screening done at birth. In the well-appearing neonate, the most common causes of GI bleeding are anal fissure, swallowed maternal blood, and allergic colitis. Anal fissures most commonly occur after passing large, hard bowel movements that tear the delicate mucosa. They most often occur midline at the 12 o'clock or 6 o'clock positions. Spread the buttocks gently for a better look. If you see an anal fissure laterally at the 4 o'clock or 8 o'clock positions, consider that the anal mucosa may have been damaged from insertion of an object and not from passing stool. Lateral anal fissures are not pathognomonic for abuse, but they're not the norm. Do further screening and ask more questions as appropriate. Swallowed maternal blood can happen especially early on as the mother's abraded or cracked nipples stealthily mix blood with breast milk. Blood, of course, is irritating to the GI tract, and seemingly out of nowhere, we get the surprise, large, bloody bowel movement. Routinely ask mom whether your neonate or infant patient is breastfed or bottle-fed. Sometimes moms will mix and match. Ask to examine the breastfeeding mother as needed. In this case, Paula is solely bottle-fed. If Paula were even partially breastfed, we could perform the APT test, which helps us to distinguish maternal from infant blood. It's simple, really. Verify that the stool sample is actually Hemocol positive first. Then, take a small sample of the stool and dilute it in 3 to 5 mL of water in a collection tube. Shake it up and let the fecal material fall to the bottom. Stool with blood in it will form a pink supernatant. So, now that we know there's some blood in the stool, whose is it? Mom's or baby's? To find out, add 1 ml of 1% sodium hydroxide to the solution, or just let the lab do it. You're basically adding a small amount of peroxide solution, and peroxide will lyse adult hemoglobin, turning the solution yellowish brown if it's mom's blood. Yellow here is good. Baby's blood is up to 90% fetal hemoglobin, which is resilient to oxidative stress. So, the peroxide solution won't do much to it. If the supernatant remains pink after the addition of the peroxide, this is the baby's blood, a pink positive APT test. The baby's bleeding from somewhere. One of the most common causes of GI bleeding in the well-appearing neonate and infant is allergic proctocolitis, which luckily is what Paula seems to have. Now, we really only make a preliminary diagnosis of allergic proctocolitis in the ED. Patterns of feeding, of stooling, and changing around the formula or changing around mom's diet if she's breastfeeding, all of that is best left to the good longitudinal care of the child's pediatrician or family physician. In the ED, we can tell Dad that Paula is doing well. She doesn't seem to be losing much blood at all, and that this is likely an irritation caused by proteins in the formula. They should continue to feed Paula through it, and she'll need to see her pediatrician in the next week, of course, with good ED return precautions. Pitfalls in the neonate and infant. A quick review. Be sure that the blood is actually from the gut and not, say, from a previously unknown coagulopathy in a boy who's bleeding from his circumcision site. Or maybe it's hematuria and there's a primary renal parenchymal cause or some urinary structural anomaly. Maybe it's a baby girl who has vaginal spotting from estrogen withdrawal, which is normal and self-resolving. Or maybe it's not blood at all. The classic fake out here is the orange or pink stained diaper. It's actually residue from deposits of uric acid crystals in the urine, and an almost always benign phenomenon in which the concentrated crystals oxidize and stain the diaper, frightening the parents. The stain has a characteristic look to it. Think pink stain without actual clot. It usually happens in breastfed babies, sometimes if they're not getting enough milk. Just make sure the child is well hydrated. Let's move on to the next age group, toddlers and preschoolers. In the well-appearing young child, through the first year to age 5 or so, things like infectious colitis and gastritis are common causes of GI bleed. In the ill-appearing young child, think about intussusception or cryptic liver disease or esophageal bleeding. Check the skin. Is that a dark purple palpable rash on the buttocks? Think Henoch Schönlein purpura. Max is a 2-year-old boy with no past medical history whose parents say that he's not been acting himself for the past several days. He's been sleeping more than usual and a bit more cranky. Max's parents just thought he had caught a bug, just like his older sister. Today, Max had a large, foul-smelling, dark red bowel movement, and they bring him in for an evaluation. Max is tired and pale, but not toxic appearing. His capillary refill is 3 seconds, heart rate 155, blood pressure 98/60, respiratory rate 38, and his saturations and temperature are normal. He's tired and a bit sluggish. His chest and abdomen are normal, no rash, no trauma. His diaper is clear now. He's not actively bleeding. But ooh, can you smell that smell? It still surrounds him, and you take one look at Max and his vital signs, and you recognize that he is in hemorrhagic shock. You quickly establish IV access and draw labs. Max needs blood now, and you start with 10 mL per kilo of O-positive packed red blood cells. His hemoglobin comes back at 8.6 grams per deciliter, and his mean corpuscular volume is 55 femtoliters. You reassess him after the first unit of blood, and he's improved. His heart rate is 120, and he appears brighter and more active. What now? Well, let's ask ourselves this. What could have caused a slow GI bleed in an otherwise normal toddler? You order a technetium-99 per technate scintigram, or more easily said, a Meckels scan. We're looking for a Meckels diverticulum, and the scan is meant to find any ectopic gastric mucosa. Gastric secreting mucosa belongs in the stomach, where a low pH is normal and the gastric lining can protect itself. Islands of gastric mucosa that find themselves elsewhere, for example in the small or large intestines, can secrete enough gastric acid to cause ulceration and bleeding. For a Meckels scan, a small amount of technetium-99 is injected IV, and then the child is put under a gamma camera to see if there's any uptake outside of the stomach. The technetium has an affinity for gastric cells. An ectopic focus is usually the culprit in the GI bleeder. It's important to note that the Meckels scan should only be used in patients who are not actively bleeding. For those with active bleeding per rectum, a radio-labeled red blood cell scan has more sensitivity and specificity. Also, if the child isn't doing well, let's make sure to involve our surgeons early. Sure enough, Max's Meckels scan shows an area of focal uptake in the right lower quadrant. He's taken for laparotomy, where an ectopic focus of gastric tissue is found, and along with it, a 5-centimeter ulceration is resected. Meckels diverticulum is the most common congenital malformation of the GI tract and the most common cause of GI bleeding in the toddler. It's a remnant of the omphalomesenteric tract. It came from a long tube that once connected the yolk sac to the lumen of the midgut, and should have gone away during further fetal development, but it just hung out some more and unfortunately left a stranded island of gastric tissue where it doesn't belong. Sometimes these islands never cause much trouble. When it does present itself, a Meckels diverticulum usually follows the rule of twos. It presents by age 2. It's believed to affect 2% of the population. It's often 2 inches in length. There may be 2 types of mucosa involved, and it's found within 2 feet of the ileocecal valve. Pitfalls in the young child. Think about common things like epistaxis or food-related misadventures. Check the child's nasal mucosa and ask about any history of cracked nose or nose picking. If you get the deer in the headlights look or a thou dost protest too much response, just ask the kid abruptly, nonchalantly, "So quick, show me which finger you pick your nose with." Often a sheepish smile emerges as the right index finger goes up. Food misadventures may cause a true gastritis, especially in the flaming hot Cheetos fans or ultra spicy crisp connoisseurs. Otherwise, think about bright red foods like beets, tomatoes, or cranberries. More than once, I've seen food coloring scare parents. A small child can eat his weight in red frosting from a birthday cake, or you may see a heavy drinker of those nuclear red colored drinks, only to be brought in later when his BM looked red to mom. A quick negative hemoccult test allays any fear. GI bleeding in the well-appearing older child includes most of what we talked about just now, but start thinking about Mallory Weiss tears after forceful vomiting, or trivial hemoptysis after viral symptoms, or maybe the child is just learning to swallow medications and he presents with pill esophagitis. GI bleeding in the ill-appearing older child. Think about varices from cryptic liver disease, or hemorrhagic gastritis, or even a Dieulafoy lesion where a tortuous small artery ends up just superficial to the gastric mucosa and can easily erode through and erupt. Ingrid is an 11-year-old girl who's had abdominal pain on and off over the past year. She's been to the ED numerous times over the past few months, usually complaining of vague abdominal pain, sometimes constipation, sometimes diarrhea. I'm sad to say that she's had a few CT scans under her belt already. After there's no obvious dangerous diagnosis, she's usually sent home with symptomatic relief and encouraged to see her primary care doctor. There is some family disruption, and primary care visits just somehow never happen. Her mother is now angry with the chronicity of Ingrid's symptoms, and she wants an answer now. As you walk in the room, you see a sullen girl sitting on the edge of the gurney with eyes gazing at the floor, shoulders hunched, feet nervously dangling over the gurney. You try to engage her, but she mumbles short responses with just enough energy to get the words out. Her mother fills the silent gap with an energetic tirade over the previous run-ins with the medical profession. So you sit. You listen. Then you listen some more. The more you listen, the verbal arrows from Mom are directed less at you personally. You've just entered their lives minutes ago, and more at the overwhelming prospect of living with this with no answers. At some point, you have to interject with some questions of your own. You learn that Ingrid's symptoms are getting worse. Abdominal pain, nausea, vomiting, fatigue, and always feeling cold. She's now not eating because every time she does, her exaggerated gastrocolic reflex causes her pain, at which point she usually has an unproductive but painful passage of bloody mucus. Ingrid looks a little pale, but she's in no distress. Her abdominal exam shows a jumpy, sensitive girl, but she's easily distracted when you talk about her favorite sport, soccer. She plays on a neighborhood team and loves it. That is when her symptoms don't keep her at home. So you think through the causes of GI bleed in a well-appearing, stable child. Nothing surgical, nothing obviously acutely medical. Her hemoglobin is 9.8 grams per deciliter with a slightly lower than normal MCV. So what now? The differential is wide open, but Ingrid is still an outpatient. The key here is connecting Ingrid and her mother with the right resources and consultants. A referral to a primary care doctor would be appropriate for most patients. She'll need an upper and lower endoscopy and a non-urgent GI referral. But Ingrid and her mother are in a slowly brewing crisis. Although the aggravation and crisis could have been avoided, here we are. They need someone to take over and help. Now, I believe that we should really save emergent and urgent referrals for emergent and urgent matters, but sometimes, because of problems with access of care or family dynamics, the right thing is not just the routine thing. You get on the line and find her an appointment with the pediatric gastroenterologist. Maybe the previous thinking with all of her prior visits was that Ingrid had functional abdominal pain. You know, the vague, self-resolving, recurrent abdominal pain in preteens. It's benign and by some thought to be a way that they cope, or don't, with the stress in their preteen life. Ingrid's case has manifested itself to be something more. What troubles us about her? The blood. The recurrent blood. This is not functional abdominal pain. In fact, she's bleeding consistently enough for it to affect her hemoglobin and hematocrit. And then there's the painful passage of just mucus. A few days later, you get a courtesy report in your inbox. Ingrid has what you suspected: inflammatory bowel disease, consistent with ulcerative colitis. About a quarter of patients with inflammatory bowel disease, both ulcerative colitis and Crohn's disease, will present by age 20. Children and adolescents may present with the classic symptoms of IBD: abdominal pain, weight loss, bloody diarrhea. But many present atypically, with isolated signs like poor growth only, anemia only, or just delayed puberty. You may also suspect IBD in the child with other extraintestinal symptoms like oral ulcers like clubbing, erythema nodosum, jaundice, or hepatomegaly. You may see one of three cardinal presentations. Number 1, a child with fatigue, a history of anemia, he's stable, he comes to the ED with bloody diarrhea. Or 2, a child with chronic diarrhea, chronic abdominal pain, poor weight gain or weight loss. Or 3, a fulminant presentation with severe abdominal pain, frankly bloody stools, tenesmus, fever, leukocytosis, and hypoalbuminemia. On exam, look for general appearance, glossitis from a pyridoxine deficiency, hair loss and brittle nails from protein loss, purpura from vitamin C and vitamin K deficiencies. Look for evidence of episcleritis or uveitis. Listen for rubs, as in pericarditis. Do a good abdominal exam, especially looking for hepatomegaly. The best way to do this is to start at the left iliac fossa and work your way up obliquely, palpating towards the right upper quadrant. If you go right for the liver, you may miss its edge because it's inferior to that. Perirectal skin tags are not uncommon in children with IBD. They also may form urinary calculi from oxalate crystal deposition. Do a thorough skin exam and a thorough neurologic exam. Treatment for both ulcerative colitis and Crohn's disease is similar. In general, the induction therapy goes like this. Children with mild disease get aminosalicylates, those with moderate disease get steroids, and those with severe disease get cyclosporin. Maintenance regimens to prevent relapse include aminosalicylates, mercaptopurine, and azathioprine. For those unfortunate to have refractory colitis, they may get an ileal pouch and an anal anastomosis. It's also called a J pouch. It's basically a type of neorectum created surgically by folding loops of ileum back on themselves and stitching them together to create a larger rectal reservoir where the rectum once was. Giving the patient his rectum back allows him to have voluntary control over his stools again and a closer to normal life. It's important when talking with families to know that patients with IBD involving the colon, regardless of the severity of disease, are at increased risk of developing colon cancer and should have surveillance colonoscopy 10 years after the first diagnosis. So IBD may present as an obvious GI bleed that needs stabilization, or it may be just poor growth for no other reason, or maybe this is a child with symptoms and known disease. Do what you can in the ED for them and make sure they get the proper follow-up or consultations as needed. Life-threatening GI bleeding in children is thankfully rare, but we have to be prepared. Just a few words on critical care and troubleshooting. Let's talk NG tubes, transfusion, proton pump inhibitors, and endoscopic intervention. These are all touchy subjects when we talk to our colleagues about upper GI bleeding in adults. For good reason. NG tubes do not reliably rule out upper GI bleeding in adults. Proton pump inhibitors are fine to use, but they're not a panacea, and endoscopy often needs to happen now when we speak of adult patients because most of these are due to briskly bleeding varices. In children, though, there aren't any randomized control trials. There are no Cochrane reviews, no systematic reviews of the diagnostic approach with upper GI bleed. All we can do is to take existing adult data and extrapolate it. Extrapolation of adult literature to children happens all the time. The bulk of critical care in children is based on what we do with adults. It's a reality that is acceptable when it makes sense. However, the reasons for upper GI bleed in adults are vastly different from those in children. In adults, mostly the life threats are due to liver disease, varices, or hemorrhagic gastritis. As we've discussed, children have upper GI bleed for different reasons. Although we have no real literature on investigation or management, we do have some descriptive data that gives us an idea about the epidemiology of upper GI bleed in kids. Shebu et al. In Pediatrics published a study titled Clinically Significant Upper Gastrointestinal Bleeding Acquired in a Pediatric Intensive Care Unit, a prospective study. Again, not perfect and not exactly our population, but in this well-done prospective study, they report 1,006 admissions with GI bleed. 103 were upper GI bleed, so about 10%, and they deemed only 16 of these clinically significant upper GI bleeds, so about 10% of those. Complications from the upper GI bleed included need for transfusion, hypotension, and surgery. On a multivariable analysis, 3 independent risk factors for clinically significant upper GI bleeding were respiratory failure, coagulopathy, and increasing PRISM score, the pediatric risk of mortality score. They conclude that clinically significant upper GI bleeds are rare in critically ill children. Prophylaxis to prevent them may be limited to patients who present with at least 2 of those risk factors. Urashima et al. In the Journal of Pediatric Gastroenterology found that a BUN to creatinine ratio of greater than 30 may be helpful to distinguish upper GI bleed from lower GI bleed in children. Transfuse children with compensated shock, especially those with a hemoglobin of 8 grams per deciliter or lower. Consider massive transfusion protocols if giving more than 40 mL per kilo of total blood products. Get your patient urgent endoscopy as soon as possible after arrival if there is active upper GI bleeding. Otherwise, according to the Belgian guidelines, stable children may have endoscopy within the first 24 hours of hospitalization. They report an efficacy of endoscopy for controlling upper GI bleed to be approximately 90%. In the unstable child, perform your usual critical care maneuvers of resuscitation with blood and protecting the airway if needed in an upper GI bleed or if urgent endoscopy is needed. It's okay to give a proton pump inhibitor. If you think the child has variceal bleeding, which is rare, you can also do what we do in adults and consider octreotide or vasopressin or broad-spectrum antibiotics and non-selective beta blockers. Cytoprotective agents like sucralfate are too late to the party to be of use. This is a rare but potentially life-threatening situation, so anticipate how the child can decline and get your team assembled. Your pediatric intensivist, gastroenterologist, and surgeon, especially if we can't get the upper GI bleed to abate with endoscopy. The sooner you activate the team, the better. In summary, the most high-yield things to think about in GI bleeding in children can be broken down by age and whether the child is well-appearing or ill-appearing. For neonates, well-appearing? Think rectal fissure, maternal blood, or allergic proctocolitis. An ill-appearing neonate? Think necrotizing enterocolitis, malrotation, or an inherited coagulopathy. For infants, toddlers, and young children, well-appearing? Think infectious colitis and gastritis. An ill-appearing young child? Think intussusception and Meckels diverticulum. For older children and adolescents, well-appearing? Think Mallory Weiss tear from vomiting or gastritis. An ill-appearing older child? Think metabolic, cryptic liver disease, or inflammatory bowel disease. For everyone, do your normal, careful thing. A thorough history and a good physical exam will guide you to know when to ramp up your investigation or your intervention. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.